Hi again. So we're back at it. This time with chapter 12. This chapter is on sexual and gender identity disorders, although very little time will actually be spent on gender identity disorders. When you look at sexual disorders, there's a lot of issues that are really related to couples and couples relationships. So it's strange to talk about these disorders without trying to first address relationship issues. A lot of times in a couple, there'll be different assumptions that each person in the couple have. Men tend to be more like orgasm focused. Women tend to be less so, not to overgeneralize. Uh, Sometimes there are differences in desire about who wants sex more often or what kind of sex, what kind of behaviors you want. Um, that happens. And sometimes there's just relationship conflict. As a therapist, it's always said that there are three types of conflicts in a relationship. It's usually sex, money, and kids, how to raise kids. And so it takes communication. We're going to be looking at these sexual disorders. If this is any interest to you and your life or relationships, I think it's best to recommend that everyone learn to get comfortable with using sexual terms. I don't care if it's the medical terms that I'll be using in today's presentation or the terms that you grew up with or that you learned in school with friends, whatever. But being able to say words related to sex is really important. The research shows that couples that communicate or can communicate about sexual activities, frequencies, behaviors, their preferences, what they like, what they dislike, what's working, what's not working, those relationships are happier and they last longer. So relationships are, when two people in a relationship shut down when it comes to communicating or talking about sex, there's more unhappiness and the relationships don't last as long. So what is a sexual disorder? Looking at DSM-5, indicates that it's a persistent disturbance in sexual desire or response that causes distress, and that is a key component. It causes distress for the person and some interpersonal difficulty in a relationship. Lasts for at least 6 months and occurs about at least 75% of the time. And a lot of times it's the distress that can actually increase the frequency of the disordered behavior. If you look at how prevalent disorders are, you see these are charts about men and women. The women are higher in most of these cases, except when it comes to premature or early ejaculation or orgasm. Men have that much more frequently than women. But pain, lack of orgasm, arousal problems, desire, typically more prevalent among women. There are a number of different types of sexual dysfunctions. We're going to talk about sexual dysfunctions and paraphilias. Dysfunctions as listed in DSM-5 are here in this little chart that you can see. I'm not going to address all those. In your textbook, the sexual disorders are generally divided into desire, arousal, orgasmic disorders, and pain disorders. I'll be addressing several of these in order from your textbook. One other thing about DSM-5, they have completely eliminated the idea of sexual aversion disorder. They actually talk about how that's more akin to a phobia and often related to trauma in one's past. They've also, DSM-5, in comparison to what you see in your textbook, has combined a few disorders. So hyposexual desire disorder and a female sexual arousal disorder is now called this, female sexual interest arousal disorder. And also, instead of having separate diagnoses for vaginismus and dyspareunia, this is called genitopelvic pain penetration disorder. They've also tried to, I should use say the word, soften the name for these two disorders, male orgasmic disorders, and now called delayed ejaculation or early ejaculation for premature ejaculation. I'll use those interchangeably. When it comes to sexual desire disorders, hypoactive sexual, so hypo means less than. So little or no sex desire or being receptive to sex. For women, this often is related to relationship problems and not feeling connected, not feeling being heard, not feeling respected, not feeling understood, not feeling emotionally connected with one's partner. Usually it's not a problem with hormones. Treatment for this usually involves couples therapy. Sometimes that can, or we're going to get into treatment later, can involve all sorts of different techniques, which includes adding variety to couples' sexual behaviors, which could include porn and varied sexual activities. It can include some medical interventions like the hormone testosterone that is responsible for desire really in men and women. So hormone supplements that way can be useful. But most typically, I put down here, it's hard to treat when it comes to sexual desire disorders. So frequently, it is about the relationship. That's couples therapy that needs to be done, and the communication has to improve. There are also arousal disorders. So feeling desire, but being unable to maintain a bodily response. Your book has a good section in it talking about like what is arousal, and it really emphasizes it's a combination of the body's response plus subjective feelings of pleasure. So it's those two things combined. So a person's body can respond, but they're not feeling pleasure. That's still not arousal. It has to be the combination of those two. And being aware that non-responsiveness in one's body is occasionally is normal. But sometimes if a person is non-responsive just occasionally, or maybe even once, that can really lead to an increase in anxiety, and that anticipatory anxiety and that increase in anxiety causes actually more problems than anything else. And so that needs to be addressed, something I'll talk about in treatment. So male sexual arousal disorder, when it comes to erectile disorder, a guy can't get or keep an erection. 1/5 of men over the age of 20 report problems with this. It's more common as men get older. A lot of times this has to do, once again, with performance anxiety, a guy worrying that they're not going to be able to get an erection. It can be related to alcohol. Now, one thing that if a person thinks that they can't get erections, there are techniques to assess whether they can get an erection during sleep, because that happens several times during the night for men. And so if the body's responding during normal sleep, but they're not able to get aroused or an erection during waking interactions with a partner, that is more psychological then, obviously. When it comes to orgasmic disorders, female orgasmic disorders, this is when a woman has delayed or absent orgasm. About 5 to 10% of women say they've never had an orgasm. It's probably it is the most common reason women seek sex therapy. It's usually often related to, I put down here, connected to low education. It's often not even being familiar with one's own body or having good sex education in one's life in high school or in college. And understanding that clitoral stimulation has to happen in order for a woman to have an orgasm. Most women, in addition, like during penile vaginal sex, need more than just the penis to stimulate the clitoris. It usually involves manual stimulation or oral stimulation. And so being able to communicate about that too becomes really important. For men, orgasmic disorders involve early ejaculation or premature ejaculation, ejaculating before a person wants to. It's the most common sexual disorder among men. And some guys even ejaculate before they become fully erect. And it's typically then reported later as being less enjoyable for both partners in a relationship. There's no real comparable disorder for women in terms of this, having an orgasm before one wants to. This is primarily a guy problem. When you look at features of premature ejaculation, this is the data out of Europe. It says 9 out of 10 men ejaculate within 1 minute after vaginal penetration. So that is something that, again, I think if it's talked about and communication happens and techniques can be discussed about how to prolong that, can increase enjoyment and can increase relationship satisfaction. So talking about how to prolong that time period would be pretty critical. So, and sometimes orgasmic disorders happen like when we have male orgasmic disorder, where there's delayed ejaculation or it's absent altogether. Sometimes this is situational, sometimes it can involve anxiety. Um, Sometimes it can involve medications that a person is taking. And so we'll get into that a little bit later. Keep in mind that anxiety is the most common psychological factor in all sexual disorders. So, and I know I sound like I'm repeating this over and over again. Decreasing one's anxiety by doing exposure therapy and talking about sexual issues with one's partner, with a friend, being able to put words to it and not feel all nervous and tense when communicating about this stuff, or even highly emotional or defensive, being able to be relaxed and communicate about sexual issues is critical to a couple's happiness. And then being able to work through problems that might are likely to be a combination between psychological and physical issues. There are pain disorders, as I mentioned. They've combined the dyspareunia and vaginismus. Vaginismus is when the vaginal walls clamp shut, and so a person can't allow penetration. And usually, this is associated with no lubrication. Sometimes there's pushing on the cervix. This can be related to like a woman's past trauma history. It can also be related to sexually transmitted infections, or I put it here in endometriosis, which is like the lining of the vaginal walls extending beyond the outside. And so that can actually create pain for a woman. And a lot of times the technique, the reason this picture is here is vaginal dilation using gradually increasingly wider, basically dildos and it's done slowly so that a woman can relax. And this is a form of exposure therapy by itself, but it's physical exposure to inserting an object like that into the vagina. Some physical problems related to some of these disorders that we've just described include obesity, which is often related to circulation problems. Same with smoking cigarettes, or even smoking weed, that can relate to it. Guys who smoke cigarettes have twice the issue with erectile dysfunction. I mentioned that antidepressants can cause erectile problems or orgasm problems. It's indicated here that 25% of erectile dysfunctions relate to medications a person's taken. Other drugs that a person takes might also contribute to sexual performance. Sometimes low testosterone, hormone problems is associated with some of these sexual disorders we've been talking about. Diabetes, that too can relate to circulation problems. Heart disease, obviously, with circulation. Multiple sclerosis is another disorder that can be a physical cause for sexual disorders, and obviously drug and alcohol use. If you look at the, I was going to show you the different drugs that contribute to problems in sexual disorders, but I thought this ad was kind of funny that smoking can lead to erectile dysfunction. So if they put out ads out like that, probably fewer smokers among men anyway. Other chronic drug use, you get circulation and nerve damage with alcohol. Marijuana can reduce testosterone, it does reduce testosterone, and decreases sexual desire in both men and women. Obviously, I've been talking about smoking, decreases blood flow, and amphetamines can create problems. Some psychological causes can relate to body image, and this pornographic image here is really this idealized idea about like what a woman's body should look like and what a man's body should look like. And men and women, maybe without even being aware of it, internalize these notions, whether it be just from media exposure or exposure to pornography. Most pornography that's created is created for men, and it bears almost no resemblance to reality at all. So people look at these images and think that it's got to look a certain way, and that's not helping anyone. It's usually people are too thin, there's no fat, there's no acne, there's no body hair, there's no sweating. And so, I mean, I put up here that, that women often think they have to be young and thin and have big breasts. Men think they have to have giant penises and big muscles. And it's like that kind of performance demand, even a demand on how one looks, can really interfere with a sexual relationship between couples. Sometimes, like I mentioned this with clitoral stimulation, that a lot of psychological causes are related to just ineffective stimulation problems. So that requires both people in a couple to be able to say, this is working, this is not working, and be able to talk about what stimulation is adequate. Men and women vary dramatically. I mean, within men vary dramatically within the group of men, women vary dramatically within women about what types of stimulation actually works for them to get off. And so it takes a lot of communication with the partner to figure out, is this all works? Is this all works? I put up there sexual anxiety. This is repeating it again. Leads to a lot. Fear of failure. I don't think I can get an erection. Then leads to, again, anticipatory anxiety, and just is going to interfere entirely with being able to have sex. Sometimes there's a process called spectatoring, when a person kind of is almost outside themselves. It's almost like a depersonalization during sex, where a person feels like they're watching themselves and evaluating themselves. So it's almost a form of social anxiety that manifests itself in a sexual encounter. Sometimes sexual orientation can be an issue. If a person might be gay or lesbian, but just feel like they need to be straight, that's not going to do any person any favors in a couple relationship. But there's a lot of stigma still associated with being gay and lesbian, and even bisexual. So being able to work through that and kind of be out to oneself and out to one's partner is important. Some other psychological causes for sexual disorders includes what we learn when we're growing up. We learn this from families for sure. We learn this in church. We learn this in schools. We learn this from friends. We learn this from TV or whatever media you expose yourself to. In church, a lot of fundamentalist religions are not very sex positive. So having shame about sex and feeling like it's dirty or sinful can lead to a lot of guilt feelings around. I can't tell you the number of students in the past that have talked about like sexual things, sexual exploration they did when they were younger, and just the amount of guilt that they carry around with them because of that then can get in the way of their relationships in adulthood. That guilt is really an interfering factor for many, many people. Some people have a strong belief that sex is for reproduction only, or that, again, it's sinful. There's also this double standard that like men can do it, women can't, or women, they're the ones who say yes or no, and the men have to be ready and willing every single moment. And those scripts don't work either. So being able to like just burst down those doors about the traditional scripts about how men should act, how women should act, and saying like, okay, these are two real human beings in a couple relationship. What do you want to have happen is a better way to approach that than anything else. Sometimes depression or trust issues, especially if there's been an infidelity, can be a problem. Sometimes the love just wanes, and if it's not stoked or can't be relit, it might mean the end of the relationship. And obviously, that's not going to work. I already talked a lot about communication. Sometimes there's just fear about pregnancy or sexually transmitted infections too. When you look at treatment, a good treatment in sex therapy will start with a physical assessment, trying to assess hormone issues, circulation problems, and then getting a full sexual history of both people and a partner is important. That also, the boundaries about that should be clear about how much each person knows about the other person's sexual history, and how much you want the other person to know about your own sexual history is critical. There's a treatment that your book talks about that I think is what's been researched to show it's very effective, called sensate focus, and that is trying to get a couple really invested in just slowing things down, building trust, intimacy, from hand holding to back rubbing. And it's not goal oriented. Actually, in traditional sensate focus, orgasm is not allowed. And so it is about trying to make one's partner just feel physically relaxed and good through, again, just like massage or through just touch and closeness. Um, it's strange. In some therapies, they call this a paradoxical intervention, because if you prescribe sensate focus and give it in the detail that, if you look it up on the internet, you can find the details of it. A lot of couples will come back and say, oh, we broke the rules. I know we weren't supposed to have sex during sensate focus, but we got carried away. I mean, ultimately, that's kind of what the therapist wants. So if you break that rule, it's okay. Also, there's specific techniques that I'm going to address next for certain issues. So arousal problems. Sometimes couples are just so determined to define sex so as in such a limited way. And so I'm sorry, I put up here that education, cognitive restructuring, that's a big part of it. Trying to readjust what your whole definition of what sexual behavior includes can really expand how one connects with another human being. So being able to expand one's definition of what sex actually is can relieve pressure, can relieve anxiety, and can allow for more exploration and treating sex more like play. In premature ejaculation, there is actually a very physical stimulation that can happen for men, where a guy squeezes just under the head of the penis for about 3 to 5 seconds to inhibit premature ejaculation. There are also Kegel techniques, where a guy learns when he's going to the bathroom and peeing, that if he can start and stop his urine flow and do that repeatedly, that increases the muscle control of the penis. And then later during sex can help allow and control one's ejaculation. So that's a specific technique also. And also just having communication. I put it on here about orgasmic disorders, where partners stimulate the penis or clitoris while there's actual communication about what's working, what's not. I talked about dilators and dildos as a way of working through vaginismus and dysmenorrhea. A lot of times that's first done alone, then with a partner. And I've talked about all this stuff, so I'm going to move to the next slide. Medical approaches vary. Keep in mind that medical medications are only one part of a solution. Medications don't cure problems that are relationship oriented. So a person can take Viagra and Cialis and all that, but that doesn't fix a relationship. So medications are only a part of an approach to treatment. I put up here, testosterone can be helpful, like for men and women, in terms of increasing arousal. But there can be some side effects to that, which include acne and more body hair. And I mean, we've heard all these, I just talked about Viagra and Cialis and things like that. It's pretty good success rate. But there can be some side effects along with that too, with headaches and congestion problems. There's also, your book talks about inserting a prosthetic cylinder in the penis that it can be adjustable, and also actual getting shots in the penis. Those have really gone out of favor since medications like Viagra and Cialis have come around. So they're just less commonly used than they used to be. Switching gears in a major way, and going from sexual disorders and what that typically means for couples, we're going to just briefly address paraphilic disorders. And as described here, it's recurrent intense urge or sexually arousing fantasy that's usually distressing or disabling, that involves inanimate objects, children, non-consenting adults, or involves suffering and or humiliation. There's a host of these. This is from a chart in your book. Some types of paraphilias include like necrophilia, you probably heard of that. This desire to have sex with corpses. Um, you can just look at all this. I mean, I thought the last one was kind of interesting, the stigmatophilia, being related to piercing or tattoos. That doesn't really seem like one to me, but apparently that is one for some people. A few more of the paraphilias include sadism, masochism. So sadism is deriving pleasure by inflicting mental or physical pain on another, and masochism, someone who becomes aroused when they're subjected to pain or embarrassment. Now, the masochism is one area that your book talks about where people who are usually have money and are positions of power over others or are privileged tend to engage in that more than other people. It sounds like that someone in that kind of high level, high status level has some sort of sexual arousal by losing that or basically being humiliated in some ways. Also, voyeurism, you probably heard of that before, where a person watches a stranger who's unaware of being watched, either have sex or get undressed. So these paraphilias are, they cause problems, obviously. It's for society. I mean, actually, when you talk about societal problems, here's some additional notes. When you look at like problems with, I mean, I don't consider sexual assault or rape a sexual thing. It's an act of violence. I mean, you look at the percent of adult women who are survivors of sexual assault and rape, that's 14 to 20%. That's 1 in 5. Unbelievable. If you look at the different types of rapists that your book describes, it talks about psychopaths and different types. It does, your book doesn't do justice enough to how we grew up in a culture where basically it's okay for men to be coercive. And that's what needs, in my opinion, needs to be addressed, is that men need to learn that no means no, and being sensitive to negative signals, being really educated about what consent means and ongoing consent. I hope at some point that you've had conversations with people you're close to about what consent actually entails. A person who's drunk can't give consent. Being clear about that, and putting the responsibility squarely where it belongs on basically men who don't take no for an answer or who think that they have a right to sex, is how this needs to be addressed, and it needs to be addressed early on. That when soon as, in my opinion, teenagers start becoming sexually active, having clear communications between parents and those kids about like, here's what informed consent means, here's what consent means, and this is how you handle that, needs to be done more consistently. Also, if you look at, sorry, I just had to went on my soapbox for a minute. You look at who engages in all these paraphilic behaviors that we just kind of went through the list. The vast majority are men. I'm sorry, just very few women engage in those. I mean, there are some, especially when it comes to like sadism, masochism, S&M, but the vast majority are men who, especially like voyeurism, and exhibitionism, things like that. The last couple slides that we have for this talk today include a little bit about gender. Just want to mention that gender identity is not the same as sexual orientation. Gender identity is one sense of who they are in terms of being a man or woman or someone in between. So you can be non-binary and identify as not being either a man or woman. So it's how one feels, who they are as their identity. Now, expression can be different because it doesn't really even necessarily have to connect to gender identity, but whether one presents as more masculine or feminine. I mean, I'm wearing a shirt with flowers on it today. That might be considered by some to be more feminine. So my gender expression might be more feminine today. And that can vary dramatically on a day-to-day basis. Androgynous somewhere in between, whether one's, and this is all societally determined about what's considered masculine wear, what's considered feminine wear, how you present yourself. Biological sex relates to typically chromosome that a person is born with, and also the sexual organs. They typically call this the sex assigned at birth. And there are some individuals who fit within an intersex category where it's not clear whether an infant that's born, whether they have an enlarged clitoris or a small penis. Um, and unfortunately, I used to show this video in my classes. Um, a lot of parents, if they have an intersex child that's born, no parent is expecting it, will frequently have surgery done on the genitals of their infant. Um, so that it is clear that this child is like a female. Typically, they make the clitoris, but typically what that does is destroys one's sexual sensitivity for the rest of one's life, and so that is a tough one for parents to have to deal with, because if they can live with the ambiguity and uncertainty, and even trying to protect their kids from being teased in school situations, it's better not to destroy the nerves to one's genitals, so that as a kid who's born intersex can grow up and have a fulfilling sexual life is critical. And then the last thing is sexual orientation, whether one is attracted to one's own sex, another sex, or multiple sexes. And here they don't have heterosexual, bisexual, or homosexual, but we have pansexual. There's all sorts of different ways to express. There's asexual, but just want to be clear, it's not gender identity. Now, when it comes to gender identity, a couple more comments I want to make, and we'll wrap up this half-hour talk. Is that the DSM-5 got rid of gender identity disorder and only talks about gender dysphoria. That is unhappiness with the sex assigned at birth, and feeling like one is a different gender identity than one is typically perceived. A response to that can involve surgery. Your book is kind of outdated, and they call that sex reassignment surgery. These days we call it gender affirmation surgery. So that one's body is more aligned with the way one identifies internally. Over and again, the research indicates that individuals who undergo this sex affirmation surgery have decreased levels of anxiety and decreased levels of depression. Although, one of the things as a therapist, it's one of my areas. I work with a lot of transgender clients in Columbia, Missouri, and typically the most challenging part is coming out to one's family and being accepted for one's self-presentation with friends and coworkers. So although surgery may be a part for some people opt not to have surgery. Many of my clients have opted for hormone treatments, so that they can appear more consistent with the way they feel internally. But it really frequently comes down to having to struggle and deal with the oppression a transgender person feels from society. And there is hope out there, and there can be just quite fulfilling lives lived as a transgender person. Your book does not do this subject justice, and I don't feel like I have today either, but I just want to introduce this as it was introduced as a last topic in your chapter. As always, I hope you learned something today.